Hi, we have Stephanie here with us today, and we're going to be evaluating the heart. So first what we're going to do is we're going to be observing the lips and the nails. We're going to look at cyanosis for the lips, and we are going to be looking at the nails for clubbing and for splinter hemorrhaging, as well as cyanosis on the fingernails as well. So that's what I'm going to be doing right now. Looking at the lips, no cyanosis. Looking at both fingernails on both hands, no clubbing, no splinter hemorrhaging or signs of cyanosis. That's good. Next, what we're going to do is we're going to look at the sternum. I'm looking at the top of the sternum, the bottom of the sternum, and to the left and the right of the sternum. I'm also going to be observing for the four valves. We're going to be looking at the... Sorry, I have a nosy cat. We're going to be looking at the four valves. We're looking at the aortic, the pulmonic, the tricuspid, and then the mitral valve as well. From here, next what we'll do is we're going to now look at the apex of the heart, so the mitral valve. I'm going to be using a pen light in viewing it at a tangential angle. If this is unable to be viewed, then you would have the patient in the left lateral decubitus position, which will make it more pronounced. After I find the apex or the mitral valve, I will then percuss. So I'm just going to lift this up just a little bit, okay? And could you put your hand over your breast tissue so I don't get in the way, okay? Yep, just move it off to the side. Thank you. So I've located the position of the mitral valve. I'm now going to percuss and just feel the rhythm and that it's bounding and pulsing correctly. Good, and that feels normal. Next, what we do here, I do not have rulers handy, but we would look at the jugular vein here, making sure that we're not having any right-sided heart issues that would cause backflow or fluid into the jugular. So I'm going to have the patient turn their head to the left so we expose the right jugular vein. And I would be taking two rulers, one ruler on the sternal angle, the angle of Louis, and then the other ruler would be on the apex or the most prominent point of the jugular vein. Then I would place that on the jugular, the largest point, and I would line it up with my vertical ruler, creating a 90-degree angle and measuring in centimeters the distance or the elevation of that jugular vein, which should be no less than 3 centimeters. After that, now what I will be doing is I'm going to looking for the lateral border and percussing the heart. So I'm just going to ask you to take your breast tissue and bring it off to the side and cover it. I'm just going to be taking, so bring it, grab it with this hand, there we go. And you can let that arm rest there. And I'm going to be taking tissue slack, dragging over and percussing, feeling some resonance, and then listening for a dull tap, which would indicate the border of the heart, which should be in line between the axillary and mid-clavicular line, lying in between there. And I'm going to be going from the third intercostal space to the fourth and fifth. Good. And everything was in line well, with the apex being a little bit more lateral, but that's anatomically correct. So now that we've done that, we're going to now palpate the 4 valves, and I'm going to do a 2-finger contact. We want to make sure we're not feeling any murmurs, and then we will do a knife edge contact, feeling for a thrill or a heave. So first we're going to be feeling for murmurs. I'm feeling the aortic and pulmonic valve, which feels good. That's normal. Now I'm feeling the tricuspid valve, which is normal. And we're going to go over to the mitral valve, which is normal. Now we're going to do for thrills or heaves. Good, that's normal. That's normal. And could you move your breast tissue? Thank you. And that is normal. Making sure to emphasize that the palms are away from the breast tissue, midline when palpating the 3 valves, then when palpating the mitral valve, making sure the palm is down away from the breast tissue, and communicating to the patient to make sure that they are comfortable and we're not invading their privacy. Now that we've palpated, now we're going to listen to the heart. So we're going to listen with the diaphragm. We're going to listen to 5 spots, and we're going to be listening to them twice. One with the diaphragm and one with the bell. Now I'll be listening with the bell. And making sure that we're putting a light touch on here, that we don't want to create that suction cup effect. I'm going to have you place your hand over your breast tissue and displace it down for me. Thank you. Good, and everything sounded normal on that. So now we're going to move to our special tests. So the first one we're going to be doing is our physiological split. So I'm going to have my patient sit up and turn the feet over like so. And what we're going to be doing here is I'm going to ask the patient to lean forward, take a deep breath in, and I'm going to be placing the diaphragm on the pulmonic valve. So I'm going to have you lean forward and take a deep breath in. Good. You can exhale. Good. And that was normal. We were just listening and making sure that the lub-dub S1 and S2 is sounding normal, if there's any exaggeration or difference in that. Next we're going to be doing is an aortic regurgitation. So, we're going to have the patient in the same position. Have the patient lean forward, and we're going this time to ask the patient to exhale. And since it's the aortic regurgitation, we're going to be on the aortic valve. Lean slightly forward. And I want you to completely exhale all the way out. Good, and that sounded normal. With something that would be wrong, we'd hear like a lub-pew on the exhale. Next we're going to do is the mitral valve. And the mitral valve test is what we're going to, these two tests, we're going to have the patient in the left lateral decubitus position. So what we're going to do here, we're going to have our patient lay on her back. And she's going to be tilted to the left a little bit, so you're almost on your left shoulder. A little bit more for me. Perfect. Just like that. Good. I'm going to come over to around the other side. So for these two, we're going to be listening with the bell. I'm going to ask the patient to exhale. And we're going to be on, for both of these tests, the mitral valve. Good, perfect. And with this hand, could you displace your breast tissue? Thank you. And I'm going to ask you to exhale. Nice big exhale. Good. And that was normal. You're going to hold that position. That was normal. We wouldn't want to make sure we wouldn't want to hear like a loud S1 sound. Now we're going to go and look at the mitral valve prolapse. So again with the bell in the left lateral decubitus position, and we're going to have the patient exhale and the most important thing is holding like a Valsalva maneuver, or like they're bearing down like they have to go to the bathroom. So I want you can take an exhale, and then you can just bear down. It doesn't have to be a big exhale, but just bear down like you have to go to the bathroom. Good. And we didn't hear you, if there was a concern, you'd hear like a loud audible click or a systolic click. And we did not hear that. So everything was normal and everything was sounding good. And that's the heart.